Good.
Um, I haven't heard anything, but let me find out from Kofi.
Okay.
Okay.
Uh,
Yes, good afternoon, wherever you may be. This is Kofi Ayim. Anytime you hear this, you know it's our sit tune special edition of Anything Africa. Yes, it's a sit tune. And we will be joined momentarily by our guest today. Yeah, dog. Yeah, we're playing the sit tune. I'm talking. Sugar diabetes, the bitter black experience, is our special topic for today. And we'll have Dr. Nelson Aluya, who is joining us from Newark. We will have Dr. William Roxon, who is a dentist. We will also have Dr. Andrew Badus, Miss Anna Padilla, and Dr. Natalie Roche, and Dr. Agnes Edu. Now, who are these people who have dedicated their time to discuss this important issue with us today? Dr. Nelson Aluya is Assistant Professor of Medicine at Rutgers University, Newark. Dr. Andrew Badu is a nephrologist. He will join us momentarily. Dr. Natalie Roche is a gynecologist and assistant professor at Rutgers University. And Dr. William Roxon is a dentist. And from Atlanta, we will be joined by Dr. Agnes Edu, who will take care of issue with our eyes, all related to diabetes. And Miss Anna Padilla will give us perspective on the social aspect of this debilitating disease which is ravaging our community. And once again, good afternoon and welcome. Welcome our guests officially. All of them are in Lanark. I can see them on the screen. And of course, we have our producer, Siddiq Abu Bakar, and our co-host, Dr. Kwame Akono, joining us, you know where, all the time. It's going to be a very special program because most of us suffer from this disease that we don't know. But why are we treating this special disease today? And I'd like to tell our listeners that this program is very, very open. We encourage professional specialists, scholars to come out with a theme that is very important to the community, and so that we can discuss it. This particular topic was developed by Dr. Nelson Aluya. And so I think it's natural that we go to Dr. Aluya, and we asked him about DM, diabetes, what, mellitus or something, Doc? And why do you
Yes.
think it's important? Before you go, I see that we've been joined by our Dr. Agnes Adu from far away Atlanta. And especially, apart from thanking everyone, I would like to give special thanks to Dr. Agnes Adu. As Dr. Aluya may know, we were not having much luck getting someone who would help us to discuss diabetes as related to the eye. I was able to contact Dr. Agnes Adu this morning, and in fact, she's seeing her patients, but she's agreed to chime in for some few minutes, so maybe we will try to give her some time, speak with us and our listeners, and then we may ask her to leave. And Dr. Agnes Adu is optometry and also a lecturer at the University of Cape Coast School in Ghana, School of Optometry in Ghana. But she has a practice in Georgia. And also, she didn't say that, but I'll tell you, she's a New Yorker originally. Grew up in Brooklyn, and then went to medical school in the state of New York. Thank you all. The screen is full now. So without much ado, Dr. Nelson Aluya. And we thank our guys from Cape Coast University. We have a bunch of students who all the time, every Saturday, they group over a laptop and listen to some of our programs. And we thank them all, and of course our listeners also from far away South Africa. Hopefully we may be able to hear from them. Dr. Nelson Aluya, why do you think it is important for us, Anything Africa, to discuss diabetes? What is diabetes?
Well, thank you for having me and the very learned specialist or subspecialist that's come on. It's a wonderful thing to come on board to talk about what concerns us so much and what we feel passionate about because it's what we deal with on a daily basis. And I really appreciate the other doctors and professionals for coming on board in such short notice because it's all about giving their time and service. They do that on a daily basis, but they take their time off on a Saturday like this to come do this. It's also a dedication, and I really appreciate each and every one of them. I welcome you all. You all on board. Diabetes, as you know, there are two forms of it. There's diabetes mellitus, which we'll be talking about today, and diabetes insipidus. Now, the insipidus one is a disorder of the endocrine system also, which involves predominantly a combination between the kidneys and the brain, where you lose a lot of water and you pee a lot. But what we're talking about today is diabetes mellitus, otherwise called sugar diabetes. Why? Because it's a disease that affects, it's also an endocrine disease that affects the function of the pancreas as it interrelates or works with the body with respect to sugar and how we process sugar. It's important that we talk about this. It has become expedient, actually, because of the increasing and becoming an alarming rate of incidence of diabetes. And as it affects each and every one of us one way or the other, as professionals or practitioners, and even in our private lives. And I'm sure these days there'll be one person or another who have come in contact with a diabetic or who has a family member or a friend or relative or coworker who has diabetes. So, but why are we talking about it? Because in 2016, in the last World Diabetic Day, WHO and the CDC actually did come up with a proposal stating that diabetes has become an epidemic. The reason being that they've come to realize the huge burden that diabetes and its attendant effects on not just on a personal and financial level, but on a global economic level, and the debilitating effects of the disease. Now, why? Um, they gave us facts or statistics saying that as of 2014, there are 422 million people worldwide with diabetes, and that this actually increased from an estimate of 381 million in 2013 alone. And if the current trend proceeds, there will be over 700 million adults worldwide that's affected with the disease by 2025. And that would almost double by 2030. That is a big issue. And we know with the estimate of the world global population as it increases, so also the amount of or the number of people who have diabetes would also increase. And the potential severity of diabetes, which the epidemiologists predict that its economic impact and death roll will surpass the ravaging effect of HIV and AIDS in the near future. Why has this become an issue? Because diabetes is a systemic disease. It affects from the brain down to the foot. I mean, brain, you have strokes. In the eye, you have issues with the eye. In the heart, you have heart attacks. In the kidneys, kidney failure. And the foot, diabetic foot. So where people lose their, their legs, they get amputated and all that. And also a huge interaction between diabetes and cancers. As a matter of fact, that is what's going on of recent, and there's huge association with diabetes with cancers. And not just that, we have other complications of diabetes that we're still finding out, and the huge interaction with the disease and the populace at large. Now, why Ghana and why everything Africa? Because the premise back in the days used to be that diabetes is a disease of the affluent, but now it's different. The prevalence is beginning to be more in developing countries where an increasing and alarming rate of individuals with diabetes are being diagnosed. And the debilitating effect is more on the poor or poorly informed and people of low socioeconomic status. And we know that worldwide, the number of people who earn less than $5 a day happen to be in most of those developing countries. And so also the effects of the diabetes will be more. In the United States, there are about 29.1 million people with diabetes, and 88 million is estimated to have pre-diabetes, meaning they have a smoldering diabetes, but they do not know that they have it. And estimate shows that in the next 4 to 5 years, 40% of them would eventually become diabetes. So it's a big issue, and it's something we that I thought it's in there that we need to discuss. On a global scale, the incidence actually from way back in the 80s to 2014, I mean, the prevalence in North America was about 5.0%. Now it's 8.3%. In Africa, it used to be about 1.2%. Now it's 7.1%. And in the Middle East or Eastern Mediterranean area, it used to be 5.9, and now it's 13.7. So there's no doubt it's an issue, and it's a global issue that was recognized that that needs to be addressed, especially as it relates to us. And I will keep the floor open, and we'll take it from there.
Well, thank you, Dr. Aluya, and that is what we do best at Jersey Ghana Radio. For our listeners, this is not a one-size-fits-all issue here. This is, as a disclaimer, this is not an attempt to cure diabetes right here on this program, but it is an attempt to try to bring awareness to our community and at least get a general advice on symptoms and maybe signs that maybe a friend, a family who are in the process of getting these deadly, well, if I may use, I don't want to call it deadly disease, but that is it. In fact, we have Dr. Roxin who also just joined us, and I know we have, except Dr. Andrew Badu, because I see we have Dr. Natalie Roche also here, except Dr. Badu, who is with the patient and he will be joining us momentarily. But like I said earlier, Dr. Agnes Adu, who was contacted this morning and agreed to come, she has to leave because she's still in her office. So we will jump to her. Dr. Adu is a doctor of optometry and also a lecturer at the University of Cape Coast School of Optometry. She has a practice in Georgia, so she's joining us from Georgia. I'm so grateful that within just some few hours, you were able to, you had to agree to come help us discuss this issue. And we have to thank our guests all the time. No one is paid. We don't pay our guests. Of course, we can't pay them, but they come to share in the experiences with our community. So, Dr. Adu, once again, welcome. Tell us, please, is there a correlation between diabetes and the eye?
Yes, good afternoon. And I want to say good afternoon to your listeners, and also thank you for inviting me to join your panel this afternoon. But yes, the direct answer is definitely. Diabetes is one of a handful of diseases that directly affect the eyeball. And for the purposes of this discussion, because your listeners are not medical experts, I'm going to try to keep it very simple so people understand exactly what happens when diabetes is out of control. So basically, the other doctor explains some of the disease processes that happens in diabetes. But basically is our body's inability to manage sugar, or our body's inability, or the insulin insufficiencies, meaning that there's not enough insulin or the body doesn't produce its own insulin. But it gets to a point where obviously it becomes a disease that the individual has to manage. The way that diabetes affects the eyes, it affects the eyes in a couple of ways. Diabetes has to do with sugar levels in the blood, in your blood vessels, the veins and arteries that run up and down your body into the heart, into the brain, into the eyes. So specifically to do with the eyes, when the disease is out of control, when the sugar is out of control and is not managed properly, the small little veins or the small little blood vessels inside the eyeball can actually rupture. It can break. And so blood will leak into the inside of the eye. So basically, one of the things that happens is bleeding of the eyes. And you hear when you go to your doctor will tell you, go see an eye doctor so they can dilate your eyes, meaning that we can open up the pupil using different eye drops and then check for those signs of diabetes. So one of the things that we worry about the most is that the patient or the person that has diabetes will start bleeding into the inside of the eyes, which can be very difficult to manage, especially if the disease itself is not under good control. So that's one of the things that can happen. Diabetes can also, over a long period of time, we find that people that have diabetes, they have a higher, higher chances of developing things like cataracts in the eye. Cataract is inside the eyes. We all have one. We are born with a lens that sits in the middle of the eyeball that helps us focus in and out of whatever you are looking at. When you're born, that lens is very clear, transparent, so you can see through it. And as we age, naturally, that lens gets clouded. And so by the time people hit their mid-60s, 70s, and up, naturally you can get cataracts because the lens gets clouded. But in the case of diabetes, people in their 30s or people in their 40s, because they have diabetes, can actually develop cataracts that are premature, meaning that they're not supposed to get it at age 40, but because their diabetes is out of control, they can actually develop a cataract. It can also affect the way you see daily. Let's say, for example, people that wear glasses, or even if you don't wear glasses, people that wear glasses that have diabetes and is not under control or properly managed, you will notice that on a daily basis or sometimes even throughout the day, your vision will fluctuate. So sometimes you wake up in the morning and you see clear. By 12 o'clock, maybe after you've eaten breakfast in the morning, by 11 o'clock, when the sugar has elevated in your body, you feel as if you can't see. Even with your glasses on, your vision can stay blurry until the sugar goes back down to the normal ranges. So you can tell from what I'm saying that diabetes is something that, I mean, even if you take just the eyeball, it is something that can disrupt your day at minimum, to something that can cause you to go totally blind if you don't go see the eye doctor. So the advice that I'll give your listeners is that, first of all, the diabetes has to be diagnosed. Sometimes we walk around thinking that we're healthy when we are not. And so see your regular physician, your primary care doctor, that can check you every year, once a year. You should know what your basic numbers are, what your blood pressure is, what your sugar levels are, what your cholesterol levels are. Those are all good, healthy practices that all your listeners should at least adopt that kind of regimen where you go to your doctor every year and have them check. So your doctor, your regular doctor, can diagnose diabetes. The people that know they have diabetes, or once your diabetes has been diagnosed, then it is also a good idea to see your eye doctor. And it can be an optometrist, it can be an ophthalmologist. There are different subspecialties within the eye field. And it can be it has to be a licensed eye doctor, meaning that a licensed optometrist or a licensed ophthalmologist. See that specialist every year. Or according to what they recommend. Sometimes if we're seeing changes in the eyes, we may have to see the patient more than just once a year. So all these things come together at your eye doctor's office. Then they will do testing to make sure that the inside of the eyes is staying healthy and that there's no bleeding or any of these other things that I've talked about.
Well, thank you, Dr. Adu. Now, Dr. Roche?
Yes, I'm here.
Okay. Let's assume, without taking into consideration, that Kofi Ayim has never seen a doctor, and I walk presumably healthy. Are there some symptoms that will show in my way of life that maybe I suffer from this disease without seeing a doctor? Is it possible?
Kofi, are you asking me?
Well, I asked Dr. Roach because I was going to try to connect it to hair field, which is gynecology, because the eye doctor just explained the correlation, but I wanted to use myself as an example as a male, and then we jump into the female aspect of it, whether there is, some correlation between gyne and then the disease, diabetes.
Oh, yeah, this is Dr. Roche. I'm the gynecologist, and I'm very happy to be on the show, and thank you for inviting me, and thank you for asking me a question. When we see patients in the office, there are some, we do have a concern about diabetes in certain populations. For example, people who are older in age, for example, 45 years and older, then they have a higher risk of having diabetes. So even without any history, anything, we are looking at that particular patient population. Anybody who is overweight, and of course, many of us don't realize what overweight really is, but they talk about body mass index, where they look at your height and your weight and try to calculate what is in the normal range. And normal is a BMI of 25 and under. So many people are actually over that. They have BMIs of 26 or greater. So anybody who is overweight or meets the criteria for obesity, we're concerned about diabetes, even as the gynecologist. Anybody who has a family history of diabetes, we take a good history in the gynecology office about what your family is doing. So if we find people who have a lot of family members with diabetes, people who are physically inactive, they don't do any kind of exercise whatsoever, are at increased risk. And then, of course, then we go by what ethnic background you have. And of course, we're talking about black people, and as black people all across the African diaspora, we're all at increased risk for diabetes because of our ethnic group. People who have high blood pressure, high cholesterol, and from the gynecologist standpoint, anybody who was diabetic during pregnancy, there's something called gestational diabetes. Those people have a much higher increased risk subsequently in their life of developing diabetes. The other thing we look at, other than these historical things and certain things on physical exam, is what symptoms do the patients tell us about. So people say they're urinating a lot, they're hungry all the time, they're losing weight without trying. The ophthalmologist talked about blurred vision. They say they can't see. They're exhausted. They're, just fatigued all the time. We're concerned about them. And if we see certain things on physical exam, like they have sores that don't heal, or they have dry, itching skin, or they have trouble with their feet, they say they have numbness and tingling in their feet, or if they have infections that keep on coming back. From the gynecologist standpoint, that's vaginitis. So if somebody has yeast infections that keep on coming back over and over, that would be one of the things that would make us concerned about diabetes.
Well, and I think we have the dentist here, Dr. William Roxon. I'm not sure. Of course, I have no idea about medicine, so pardon my ignorance. But what has diabetes got to do with teeth?
Yeah, Kofi, this is Dr. Roxon. Thanks again for inviting me as well. And I've been listening to the other physicians talk about the effect of diabetes on the various entities. Well, we know that diabetes does not just affect one aspect of the body, pretty much affect the whole body from head to toe. Now, when we when we get to the mouth, we know how diabetes affect gum disease. What we call gingivitis or periodontitis is really it's a chronic gum infection, and studies have shown that people with diabetes have about 4.2 times higher rate of developing periodontitis, which is inflammation of the gums and the loss of bone and attachment to the teeth. So it's very important that people with diabetes see their dentist frequently. Sometimes not just twice a year for cleaning, but at least 3 to 4 times a year. They tend to lose more bone around their gums because of chronic infection. Since diabetes is affecting the entire body, they really need to have every aspect of your body checked. And then when we come to generally about 80% of adults tend to have some sort of gum disease, but those with diabetes even really, really high incidence. And so one way to figure out whether your gum disease is under control, or if you're not sure what's going on, just look at simple signs like, okay, the way your denture, if you wear denture or partial denture especially, are they fitting right? Do your teeth come together right? Do you generally get like a dry mouth? Do you see like pus around your teeth, around your gums? Do you see the gums pulling away from your teeth? Do you see that your teeth are shifting? These are all signs of periodontal disease, and with that, it's actually more. Studies have actually shown that patients who are diabetic, once they control their sugar level, ultimately their gum issue also is resolved significantly. So it's like you said earlier, like everybody, every specialty is talking about, like it affects generally the entire body and not just one system.
Well, thank you, Dr. Roxon. I think maybe I might have to call my dentist and go have a checkup. My dentist secretary keeps calling me now. I keep putting it off. I'm going to run to make that appointment. This is scary.
let me go back to Dr. Roach. Someone wanted to say something, Dr. Roach, you?
Yeah, I was going to say that, when people have missing teeth and say they need implants for replacement, if their sugar level of are not controlled, really you can't place them, because you do so, the implant is going to fail. So that's why it's very important that we all check. If you have a patient with diabetes, you really have to check them, test your sugar level before you do certain things, certain procedures.
Well, let me throw this out. We'll go to the social aspect of it, where Cesar Padilla will get a chance to explain how it's affecting the social and the healthcare aspect of the community. But I think last week, a report came out, actually, from Ghana. And the president of the National Diabetes Association of Ghana, who is Miss Elizabeth Esi Daniel, said that about 3 million Ghanaians have been identified as living with diabetes. About 3 million. And if I'll read this. She disclosed that 3 out of 9 Ghanaians suffer from diabetes, saying it is a chronic condition which could result in other health conditions such as kidney failure, amputation, stroke, impotence, and eye disease that could cause blindness, quote and unquote. I think this is scary. My question to maybe Dr. Aluya, you have been up, at least so far as I know, on these statistics. Ghana is roughly about 25 million people. And the president of the Ghanaian Diabetes Association is saying that about 3 million people are living with diabetes. And obviously, some of them do not know. Now, maybe Padilla will help us here. How do you think the government should try to re-educate the people about awareness, even though we are not in Ghana now, but in general, social interventions and education and awareness? What are some of the things that are just basic to bringing up this issue to the fore of a given population? Our community. Yes. Padilla?
Yes, hi. I just want to say thank you for inviting me. And touching on the base of how it touches the community, being a patient navigator right here in Newark at University Hospital, I tried my best to educate my patients and the community with resources. There's a lot of resources out there where patients can get assistance for the supplies, which can be very, very expensive, including with insulin and stuff. I try to teach them how to go about applying for assistance that can help them with getting their medications. Diabetes is a very, very expensive disease, and the strips and the medication and even for treatment, it could be overwhelming for patients, not only on hospital inpatient care, but like I said, for prescription medications to complications, the diabetes supplies, the physician office, making sure that they go to the eye doctor, the dentist, the podiatry, and their everything is very expensive. So I do my best to teach, and I teach them everything that we do with diabetes and I know it's very expensive, so we try to do it free of charge, even in the community. I assist with trying to get them supplies if they need it, because I believe that every patient that is a diabetic needs to be tested every day to ensure that they stay in control. So how is it affecting our society? A lot of people can't afford the disease itself. They go without testing. Their diabetes is uncontrollable because they don't have the resources or they don't have the knowledge. So I try to make it my fight with them to learn, to educate, and to assist.
Well, okay, excellent. Let's try to extrapolate and go to Africa, where I believe a whole lot of people do not even know they live with the disease. They may not even know that there's a family history of, this disease. What approach should they do? What approach should a government take to try to bring awareness of this? Because in the introduction, Dr. Galea explained that it is no longer a disease of the rich people. It's a disease for everyone. The poor, it is colorblind now. And so many of our people living in Africa do not have access to, Western medication or hospitals. My question is this, and this is open to all of you. What should a government do, any government in Africa, to try to bring awareness into the people, the populace of this disease? Because without that, they may not be able to prescribe lifestyle changes. First, the people must be aware that something like that exists. I don't know per se if my family has the history, and there could be others who may have grown up with foster parents. So the foster parents may not have it. He or she may have it. So I am concerned that how do we bring it to the fore of the people? Should it be something like maybe non-profit organizations taking it upon themselves? Should it be that the government should actually embark on serious campaigning like they campaign for votes and elections? Or a marriage between civil and civic organizations and the government, so people start to become aware? Because from the statistics given by Dr. Nelson, it's frightening. Who can come in here, please?
Yeah, Kofi, I'll come in at this junction because I've been a huge advocate for this. The reason being that I just gave you a small synopsis of the statistics. It's much more bigger than that. Like I said, 29.1 million people in the U.S. Know they have, or it's estimated they know. 88 million do not. 422 million people right now worldwide. And how many of those don't even know out of the total world global, 7.5 billion people with diabetes who don't even know have diabetes or are pre-diabetic. In Africa, as of 2014 and presently, even last year, 2016, it's estimated that 25 million people have diabetes. And you just stated Ghana, reported 3-point-something million.
Yeah,
but I'll tell you this, right? Knowing how much we keep data in Africa, I'm sorry to say, we know that's underreported, grossly underreported, because so many more people having issues, signs and symptoms of diabetes and the complications of diabetes, and they're dying. And unfortunately, they're dying in the 50s, a few of them even in the 40s. I've had reports, I've spoken to people. With the cost of diabetes, in the United States in total, estimates direct cost is about $200-something billion, with up to $400-something billion in diabetes-related disease is spent on diabetes annually. That's a staggering amount.
Wow.
Now, in the UK, it's said that they spend about 26 billion pounds. But how much in Africa are we spending? $1 billion for diabetes, with a total of 25 million people with diabetes. So you see the disparity in the spending as regards to the number of people who have diabetes, which we know is grossly underreported. In the United States, it's estimated about $200-something a month. That's with people without complications of diabetes are spent on diabetes, the average cost really, because I mean, depending on the complications you have. If it's the eye, you have to see the eye doctor. If it's the kidney, then you're on dialysis. The cost, rises exponentially. But if you just on a regular basis with no complications, newly onset, you just want to manage it, it's about $212, and that's the same cost that's been applied by WHO in 2016. That the average cost of diabetes in Nigeria, that's what it will cost, the average Nigerian to manage diabetes. And if you put that in terms of now with the current exchange, that's a lot of money, and how many people can afford that? So you see the debilitating effect or the complications would affect them more because, one, they have no knowledge about the disease. Two, and if they do, what medications are they getting? And how can they verify the authenticity of those medications, and even if they're accessible? And not just that, I mean, like I said, we just brought experts in here. We also have an endocrinologist who has to be involved in the care of people with diabetes. You have a gynecologist if she's pregnant, the ophthalmologist, the nephrologist, and the cardiologist, as a matter of fact, also. And then talking about the podiatrist and the orthopedic surgeons who needs to be involved from one time or the other, and then even vascular surgeons. So if you translate that into our perspective in Africa, how many endocrinologists do we have? How many nephrologists do we have? Or how many dialysis centers do we have in the whole of Africa? How many cardiologists or neurologists? So it behooves us that, yes, we need to stay on top of this and get ahead of the curve in managing this disease that I describe as an impending tsunami. That's been described officially now as an epidemic. The reason being that, one, in fact, let me go back a little bit. I remember, I think, what year now, where the AU, the OAU used to be called, Organization of African Unity now, stipulated that I think 15% of each individual country's budget should be put on or spent on healthcare and healthcare, management. But guess what? How many of those countries spend up to 15%? On the average, they're about 6 or 7%, of which only countries like probably South Africa, Mozambique, and some of those South African countries spend a little bit up to 10 or so percent. The rest is grossly less than 5%, as a matter of fact. So,
Dr. Nelson,
right.
I hate to cut you here, but you continue. I indicated to you that our eye doctor would have to leave at like 2:45, and I think because she's still seeing patients. But let's hold on where you left. Let me just bring her in one more time, and then before she leaves, I wanted to ask a follow-up to what you said about the AU recommending like 15% of a given budget in a given African country dedicated to health. And Dr. Du is a lecturer at Cape Coast University. So maybe she might have an idea. My question to you, Dr. Du, is this. What sort of intervention should a given government in Africa put in place to at least bring awareness to this disease? Please, if you can help us with this, and then you may, and if you have to leave, sure, you can leave, but we'll be here till 4 p.m. So if you attend to a patient and there is time, please call us back so we can go. We can, but Dr. Edu, we know you have to leave. That is why I had to pause Dr. Nelson for you to try with your experience as a lecturer, a professor at the Cape Coast University. Yes. What sort of intervention?
Yeah, thank you, Kofi. Well, Africa, our medical or healthcare issues are plenty. I mean, you peel one layer, the next layer is there waiting for you. So I'm not even sure it's a one sentence answer. But what I think, especially in Ghana, when I'm there lecturing, what I see how the healthcare system is in Africa, specifically in Ghana, is that we don't spend any time at all or any of our resources on preventative medicine. Preventative medicine, for example, with diabetes, for example, if you wait till your sugar has hit 1,000, we've lost the game. We've lost half the battle. So what I think governments in Africa, specifically in Ghana, should concentrate on is preventative medicine, meaning that we should get not only awareness, but we should have incentives, programs, however, whatever the authorities, any ideas that they can put in place to get people to get to their doctor's office before it's too late. And so in America, the way the healthcare is practiced in America, a lot of our attention and our focus it goes into preventing the disease from happening to begin with. That means that getting regular checkups. And so in Africa, I know that when you only go to the doctor when there's a serious problem or when somebody falls down. But really, we need to start educating the citizens about getting in regularly, once a year, to check. When I started talking, I said that every year you should know what your basic numbers are, what your sugar level is, what your cholesterol level is, what your blood pressure is. And it could be nothing. And so in Africa, I think we feel like if there's nothing wrong, there's no need to go see the doctor. So that's where I think we should start, and that's where I think we should actually concentrate our efforts, is really disease prevention or preventative medicine.
Well, thank you so much, Dr. Adu. And you're at liberty to leave, but we hope you see next patient and come back before.
Yes, and I will do that. I have your program on all the time. I listen to you all the time, and I have it on and I have it on in my office. So I am actually tuned in, and if I can come back, I will definitely join the panel.
Wow. Thank you so much. And before Dr. Nelson continues, we have our Dr. Badu has joined us. He was also seeing a patient, and Dr. Roxley also had sent a message earlier that he was just going to be a little bit late, but he will join us, and he has indeed joined us. This tells us about the dedication of some of our people, who give. These are specialists in their own fields. Saturday, we have professors lecturing in medical schools and all this. Maybe they would have been marking papers, or Miss Padilla out in the community trying to re-educate people, but they have volunteered their 2 hours here, and it's something. Dr. Aluya, please go on with your narrative. I'm sorry, I hated to cut you, but we're going to lose our eye doctor, so.
Right. So that's where we need to start from. When we talk about percentages and how much our governments are spending on healthcare, it's the change has to come from the top and down to the bottom, because like the ophthalmologist said, or the optometrist said, it's a huge layer, and then every layer you peel off, there's another layer. And we need to begin from there. So the essence is, it's not a one size fit all, and it's something I think needs to be addressed almost in an expedient way, the way the Ebola disease was addressed, because we felt, that killed people so instantly, everybody jumped on board. But because this is killing people so slowly on an individual basis, a lot of people are not paying attention to it, and they think they're not affected. But like I said, as we go on, we'll find out there's a member of your family, your friends, or co-worker, or somebody who has diabetes, and you will get to meet one. So it's a disease now that everybody needs to get on board. And if I have to say something about what we could do about this, I actually wrote a proposal not too long ago on steps how we need to approach this. And in my idea, the first step is actually to talk to the practitioners themselves. I mean, people in the practitioners in those African countries, meaning the doctors, the nurses, and everybody else, so that they get the awareness and create the awareness among them themselves. Because like I always say, if you come to meet me, who is a doctor, you put all of your trust on my hands because you know I will do the right thing. But if I do not know to screen you for certain things, you have no idea. I may just do one or two and let you go, and you're satisfied that you saw the doctor already. So it behoves me to take those steps, to take on preventative measures to prevent you based on your risk, meaning I'll assess you and see what your risks are and screen you for each and every one of those things. Like Dr. Roche said, if you're obese, you have a strong family history, or you were pregnant, you had diabetes when you were pregnant, or you have a wound that's not healing. Those are things, or you're waking up 4 or 5 times at night to pee. Those are, early signs and symptoms of diabetes. Or you have burning sensations in your leg that you do not or cannot explain. Those are things that we need to know. So doctors and other professional, healthcare professionals also in Africa needs to know and understand those, so that everybody who comes needs to be screened. And like the ophthalmologist said, know your numbers. In my view, every individual ought to have a baseline screen of your A1C. So if you're listening today, please ask your doctor, what is my A1C? Because if you know your A1C, it will give you a perspective of where you are in the whole spectrum of diabetes. Are you not diabetic? Are you pre-diabetic? Or you're diabetic already? So you need to know. So if they find out you're pre-diabetic, then guess what? You need to take steps to mitigate you progressing on to becoming diabetic. And that means lifestyle modifications, what you want to eat, exercising, and all that. And if all of those things fail, then you may have to be on medications to even prevent that. Because on the average, on the expert level, the microvascular changes of diabetes actually begin when you're pre-diabetic. So by the time you begin to become diabetic, you find out that it's almost too late. And from pre-diabetes to you being diabetic, it takes on the average, statistics show, 5 years. So you find a smoldering microvascular disease complications of diabetes 5 years before you actually become diagnosed with diabetes. And then we wonder why people go blind, or why so many people are on dialysis, why people get strokes or heart attacks. That's the reason why. So if we catch them early, you can intervene. And that's how you can take it. So creating a national awareness among practitioners themselves, involving the NGOs to come on board, and everybody else who can have a stake in this, the federal government, the state government, the local government. What we're doing right now on radio, on television, creating flyers and workshops, yes, those are things we need to do. And then we have secondary prevention, where even before that, we need to create a national database. I mean, here in the United States, they have a database for it. Just like you just said, the Ghana Diabetic Association, they should create a database. Each African country should create a database for themselves. And then we should have an African nation collective database, so we know how to fight the disease, what it costs us to fight the disease, what complications that we have of people who have diabetes, and then how much we need to spend to mitigate, handling the disease. Those are some of the things that I think ought to be done, so we can help and then help prevent and manage the disease. And not just the NGOs, but the pharmaceutical companies need to be on board too. I mean, they did exceptional work on HIV, where HIV medications now is practically almost free in Africa. a number of other developing countries. Why? Because they understand the effects of not taking those medications. So I see no reason why even the pharmaceuticals cannot come on board with this, where they can make a medication even as much as metformin or glucophage free for everybody, or even as little as $1, where everybody can afford. In the United States, they understand the fact, and that's why if you go to some pharmaceutical companies or Rite Aid, I think it's free for you. You know, you go there, you get your metformin for free, and some other medications are free. So the pharmaceutical company with the other NGOs and the government intervention, we should make some drugs free or almost free also in Africa.
Well, folks, you are listening to Jesse Ghana Radio, Anything African, our weekly intellectual program that we get people, specialists, scholars, people with experience in their field, and then we discuss this. And we do this all the time. I'm so glad that Dr. Du just said on air that she listened to our program every Saturday. I didn't know that because she's never called into this program, but I'm glad. So at least people listen. And we'll take that opportunity to welcome Dr. Andrew Badu. And actually, I forgot. So let's go back to Sankofa. I think our doctors, we have to let you tell us, those that I do not know, where you practice, how people can get access to you. If they want to, to come see you, we will do that. But let's go to Dr. Badu, who has 2 offices, one in East Orange, one is in West Orange. And Dr. Badu happened to be my doctor, and Dr. Roxon also happened to be my dentist. Dr. Badu, let me ask you a question. I know that if we open the lines, maybe people may or may not want to ask. 2 questions. First, Dr. Luya said something, A1C. I don't know what A1C is, so you have to explain. And my second question is, does diabetes cause impotence, and why? So tell us what A1C is, and then you answer my second question.
Okay, thank you, Kofi. Thank you very much. And again, my apologies for coming on the show late. I was, as you stated, in the office seeing patients, so it took longer than expected. So again, my apologies to you and your audience and to your guests on the show. To answer your question, A1C. Well, A1C basically stands for the glycemic control, meaning that it reflects how well or the measure of your blood glucose for the past 3 months on the average. So it's calculated and it's measured, and as Dr. Leah stated, if your A1C is more than 6.5, it basically reflects the blood sugar greater than, for fasting, greater than 126 on the average. So that by itself means that you're diabetic. So as indicated, it's a good way to screen for somebody who may be diabetic or who may have diabetes or pre-diabetic based on that. So A1C 6.5 or greater is indicative of somebody being diabetic. But at the same time, if you do a blood test, just a routine blood sugar test, which is fasting, and the level is 126 or higher, is also indicative of somebody being diabetic. But if the patient or the subject had already eaten, and it's a non-fasting, meaning that you had eaten at any point in time, if it's more than 200, it's also indicative of being diabetic. So that's for your first question. Okay. Now the question about what does diabetes cause impotence? Mm-hmm. That by itself, I guess, is a maggot of a question, because it deals with the baseline of what diabetes does to the body. As we have been alluded to earlier by Dr. Luya, and again, I do apologize for not being here, so I may be repetitive with my comments. Diabetes by itself, one of the things it does is it affects the small blood vessels that goes to the body in different parts of the organs. Meaning that's how it's able to affect the kidney, it's able to affect the eyes, affect the heart. It could affect the brain, your skin. So by affecting and decreasing blood supply to
genital area, or as you ask, the penis, male genitalia, it kind of blocks blood supply to those areas, and it affects the nerve sensation to those areas. So that is how it could produce or attribute to impotence in a male gender.
I see. Now let's go quickly to Dr. Roach. Dr. Roach, if you may tell us, if you have a practice somewhere and you want to tell us where you do practice, in case someone wants to see how you can be reached. But the question is this impotence. How about female?
Well, the females don't have the same kind of situation with males. But there are many things that can affect sexual function, and that is because diabetes, is particularly if it's poorly controlled, is going to affect things like the likelihood of having vaginitis. So we already talked about looking at candida or yeast vaginitis and the difficulty with it coming over and over again and being a severe form, and that's associated with poorly controlled diabetes. So anything that affects or an infection in the vagina, of course, is going to impair a woman's sexual function. So those are the main things related to sexuality for women, is the likelihood that they're going to have some sort of infection that is going to impair their sexual function.
How about infertility in a woman? Can it cause that?
Well, the thing that is most problematic is that the diabetes itself is not generally going to affect the fertility of the woman, but some of the other problems associated with obesity can certainly affect fertility. So people who get to the extremes of obesity sometimes have decreased fertility because it messes up some of the female hormones. And once people do become pregnant, diabetes absolutely, if it's poorly controlled, affects the pregnancy outcome. The miscarriage rate is higher. The likelihood that the fetus will be abnormal is higher because we heard talk about that hemoglobin A1C, which can be used to diagnose diabetes. We use it to predict the likelihood that there's going to be an abnormal fetus. Because when the hemoglobin A1Cs are very high, for example, over 15, then the abnormal pregnancy rates can be up to 20 and 25%. Because sugar, during the first part of the pregnancy, the very early pregnancy, when people don't even know when they're pregnant, that first, 4, 5, 6 weeks, that high sugar level acts as like a poison to the developing fetus and causes abnormalities. It can affect the development of the heart. We see increased problems with the central nervous system, for example, neural tube defects like spina bifida. So while people are not really aware of all these issues, it's not only pregnancy loss that you'll miscarry, it's also increases the likelihood you'll have an abnormal pregnancy.
Now, how would it affect directly an unborn baby?
Well, what happened? Many ways. I already said that when the fetus is developing, high sugar levels actually interfere with the development of the fetus, and can cause abnormalities in the fetus that cause cardiac, heart developmental problems, as well as problems with the central nervous system, where you have developmental problems with the spine and the head. If your sugar is out of control, then the fetus can become very big. And at the time of delivery, there can be damage to the fetus. And some of that damage can be permanent. It also increases the cesarean section rates. They get so big, some of these babies, that they can't even deliver. If the blood sugar is out of control, it increases the likelihood that you'll get hypertension during pregnancy, which can increase the stillbirth rate and increase the rate that the delivery will have to be done prematurely. So it increases prematurity rate. And the babies that are born to diabetic mothers, they are affected by that high blood sugar because it increases their insulin levels. So those babies then get very low blood sugar after delivery, and they have some problems processing bilirubin, so their bilirubin levels can go up. And babies born to diabetic mothers tend to, in later life, actually be obese themselves. There's a greater likelihood you'll end up with obese children, and also that will increase the likelihood that the children will be diabetic later in life. So some of these problems are actually things that begin in utero. So we talk about the high diabetes rate, but some of these things are predicted by what happens in the uterus. So if you're a diabetic mother and you're a big baby, you're at increased risk yourself of being a large overweight child who's going to develop diabetes early in life. So these issues in terms of prevention are really profound because they're not only affecting what happens with the individual patient, but also maybe affecting what happens with their offspring in the next generation.
Well, we will go to Ms. Padilla for her to tell us about lifestyle as she's experienced in the community. But let's go back quickly to Dr. Roxanne. And then also after that, Dr. Badu will come and tell us what are the causes of diabetes. In fact, I've started getting questions, but after these three people give us some narratives, we will open the line for our listeners to send in text message or call in to answer questions. If you want to call in, the number is 973-409-6422. 973-409-6422. You want to send a text, address it to 201-704-5838. 201-704-5838. I have, my thing is, text messages are coming in. But so let's go quickly to Dr. Roxanne. So Dr. Roxanne.
Yes.
Let's assume that I have issues with my dentals as a result of diabetes. Would it be my dentist that I have to see to try to take care of me, or go back to my diabetic doctor?
Well, what we see in dentistry is basically one part of the complications of diabetes. Actually, with American Society of Periodontology says that diabetes and gum disease are sort of like a two-way street. You know, if your sugar level is high, your chances of having periodontitis is also high. So when you go to the dentist, there are certain signs that we can see that are, well, you may have diabetes, or that will probably say, you know what, go see your physician, or we can just do a simple blood test. One of the signs you can see with diabetic patients in the chair will be, like I said, a dry mouth. You could also see like the puffy gums, and some of these patients, when you're trying to treat their periodontal disease, which is the gum disease, and nothing is working well, sometimes you have to add, give them some antibiotics while you do the deep cleaning. And if it's still not working well, that means the patient definitely has diabetes. And sometimes, like I said, by controlling the blood sugar, your treatment will be quite successful. If you don't, then it becomes a challenge.
Now, Ms. Padilla, you have been out there in the community, at least trying to help people. Are people of color prone to diabetes from your experience, more so than white people?
Being out in the community, yes. There is more of the Black community along with the Hispanic community that are more interested in learning about diabetes and what is out there for them. Being out there, I do my best in taking education to them, trying to recruit people to attend classes to learn about diabetes and what can be done to help them improve themselves with learning in what is diabetes, how to monitor their blood sugar and why, what to look for in managing and preventing complications. We teach them how to properly make correct food choices that can help them with with their sugar glucose levels, and exercise. You know, we take it to them. We we try our best to educate, because awareness to me is the first thing that should be out there, making people aware that we are at high risk and that there is things out there that can help them manage their glucose level. So with education and awareness to the right community, I think that diabetes can be controlled. So in the area that I work in, is a very high Black area and Hispanic. So I target them because we are mostly at high risk for the diabetes.
Okay. Well, thank you. Now we'll go to Dr. Badu. And Dr. Badu,
sorry, Kofi, if I may, piggyback on that a little bit.
Sure, please.
Just to give yes, it is. To give a little bit of statistics on that. True. In the United States, the American Diabetes Association, actually gave the diagnosis rate of based on race, and it was stated that Caucasians, non-white or non-Hispanic %, Asians 9%, and of which non-Hispanic blacks are 13, about, and highest incidence actually is among Africa, with a 15.9% incident rate.
I did not get the percentages well. Can you repeat that?
Oh, okay. That's non-Hispanic white. Is about 77 point. Asian Americans, 9%, Hispanic. So, and then in blacks, meaning 15.2%, which 15.9. And if you put a span of everything else based on applications, blacks actually fare worse than any
race.
Racial components. So, and that's why it's imperative that we talk about this, because the future, looking at the African Americans in the United States with all the further facilities, with all the awareness put to them per se, and draw inferences to what's going to happen to us in Africa. And that's why it's so important that we discuss about this, because our numbers back in, if all of these complications in the United States, you can imagine if you even going to do worse on a global scale if the perspective analysis. And that's why we need to talk about this.
Thank you so much, Dr. Olivia. Let's go to Dr. Badu. The question someone wants to know, send the text, that what are the causes of diabetes? Dr. Badu, and it's to you. And also, can you elaborate on, I know or I hear there is type 1 or 2. What are the causes of diabetes? And then can you explain the inherent difference between the types?
Okay, thank you. I think I just reiterate what Dr. Aluya was saying, because I think some of his comments were broken up. So I think at a later day or later time, we should have him recite the statistics again. But I think what Dr. Aluya was basically trying to show was that diabetes has a higher prevalence in the African American community. And because of that, we tend to see more of the adverse effect of the diabetes in that particular population of people. Now, to getting back to your question, Kofi, we'll start off with what is type 1 and type 2. But in essence, what is diabetes? I mean, we've been talking about it. But diabetes in its simplest form basically means high sugar in the blood. Okay. Now, in general, the simplest way to look at it, our body uses sugar for energy purposes. And so when we eat, our body metabolizes the food into its minute components, the glucose, and it's getting used. Now, the glucose that gets absorbed to our intestinal tract gets into the bloodstream, but it doesn't function in the bloodstream. We need the sugar to be in the tissue aspect of the body to be worked, to be used as energy resource. So the modality of being able to transport the sugar from the blood vessel side into the tissue side is helped in essence by what we call insulin. Insulin is a hormone that is produced by the body. Now, this is where type 1 and type 2 comes into play. Type 1 diabetic, but in essence, basically means that your body does not produce insulin. And insulin comes, as I said, as a hormone from the pancreas. And so we tend to see that mostly in young adults for type 1 diabetic. Type 2 diabetic or type 2 diabetes, in essence, refers that, well, at some point in time, your body was producing insulin, but over the years, either the amount it was producing is no longer sufficient to meet your body requirements, or the amount that is being produced is not working effectively. So that, in essence, means that the blood sugar stays in the bloodstream longer than it should be, and hence you have what we call diabetes. So that's how type 1, type 2 diabetes is, and how to differentiate between the two in the simplest form. Now, in terms of the question about the damages, well, as I had alluded to before, diabetes affects almost all the organs in the body, or the major organs in the body, and hence that's why diabetes is such a bad disease. It affects the eyes, it affects the heart, your brain, it could affect your skin, the kidneys, when it affects the brain, you could get a stroke. When it affects your heart, you could get a heart attack. When it affects your eyes, you could go blind. When it affects your skin, you could have a cut or ulcer that doesn't heal well. When it affects the nervous system, besides having a stroke, you could also get numbness and tingling sensation. You could get some, basically nervous system dysfunction from that. And of course, the last, which deals with my area, is the kidney. And when it affects the kidney, it damages the filtering mechanism of what the kidney is supposed to do. So the kidney doesn't function as well as what it should.
Well, tell us, any one of you can tell us, what causes diabetes? It's so scary because it almost affects every part of the body. Where does it come from? Genetics, our lifestyle, and I will add a follow-up question, then we'll open the lines for callers. About the food we eat in Africa. Does it have direct impact or negative effect on us? For example, eba or kenke. I know my doctor tells me don't eat kenke and all this, but okay. Our food and our lifestyle, does it have impact on diabetes?
Well, my approach and my belief and my philosophy dealing with diabetic and diabetes is that I think it has a lot to do with, definitely a lot to do with our cultural diet. Who gets diabetes? I mean, I strongly believe that, the kind of food we eat as we are young to our adulthood has a great tendency to determine who gets diabetes or not, because the way I look at it, or I approach it, is think of it as, an overuse system. This is referring to type 2 diabetics. Type 1 diabetic is all genetic per se. You can say where your body does not produce the insulin. So that's a different entity. But when we're concerned about type 2 diabetics, so you're dealing with the principle that either your body stops producing insulin or whatever is around is not being able to be utilized effectively. So I believe strongly that the food that we eat it puts a strain, so to speak, on our organs, to produce the insulin or to have the the process, the glucose metabolism. And I think as we get older, the strain on the body or the overuse is what causes you to become more prone to getting diabetic. And I think that goes to the core of why we need to start our children to eat better, healthier when they were young, so that you don't end up having the risk of developing diabetes in the future.
Well, 973-409-6422. You are listening to Anything Africa, our weekly intellectual program, and we have a bunch of specialists and a community expert helping us to dissect this deadly disease that basically most of us may have it, we may not know. And from what we are saying, from what we are hearing from our experts, it's extremely important that you see your doctor. See your doctor. If you are around here and you don't have a doctor, well, yes, of course. These doctors have practices, I believe. Dr. Roxanne has a practice in South Orange. You just go, you call the office, and he will take care of you. So are all our doctors. Of course, we may, before they give a closing remarks, we will touch on all of this. But you have a question, 973-409-6422. Let me see, because I hear my phone, the phone here making noises. Now, I have another concern though. We have some people, at least in Africa, who are like maybe 70 years, 80 years, or even 90, and they've been eating the food that they've been eating from, from their youthful days up till now. They are still living. I don't know whether they have ever checked whether they have diabetes or not, but at least if you are like 80 or 90 years and you've been eating KK all your life, or fufu, or eba, or gari, and you are still living at this age, this advanced age, like 90 years, what is it? I don't get it here.
Hello?
Yes.
I have a question.
You have a question? Okay, yes. Your name and where are you calling from, please?
My name is Janice. I'm calling from Newark, New Jersey.
Okay, go ahead.
Dr. Aloya Nelson.
Go ahead with your question, please.
Okay, so he said that genetics plays a part in diabetes. I have a family that has diabetes. What test particularly do I have to test in order to see if I have this diabetes? Is it the A1C, or is there a particular test that I have to do to determine if I have it, because I have a family that has diabetes? Okay, I have a family that has diabetes. What test particularly do I have to test in order to see if I have this?
Give a little, summary. Diabetes is a
Determine if I have it, because
to know
that has diabetes
on a daily basis. Like I said, Dr. exceptional work on describing, what it is. All through generations, all the way back from by the Egyptians, and it's been with us. But the difference now is
you are breaking up a little bit. I'm not sure. Dr. Badu and the rest were not breaking up, so I don't know whether it's where you are now. But you breaking out. Yes.
Oh, can you hear me better now?
Yes. Go ahead.
Diabetes, right? Diabetes has been with us all through human reports about the Egyptians and up in China and everything else has been with us. Where they came up with, people who back in the days will pee, and you see ants gathering on the urinate, the urine on the ground, and then they begin to think, oh, this is a disease of sugar, where when you see ants gathering on it. it's been with us. In a perspective, modern perspective, diabetes is a disease in evolution. We learn more about it on a daily basis. Research been going on to know the disease, understand the disease, and how to better manage and prevent the disease. Now, I'll give you a short synopsis of it. There's type 1, which no doubt is genetically based. There's the HLA, DL3, and DL4, components of it, and that's on a more molecular level, where you find out that it runs in certain families, and there's inheritance of the disease. Now, you have the type 2 diabetes, which is the one that occurs more in adults. Now, the type 1, usually when the pancreas fails in itself, it can fail from one or two things. I think we've had reports where pancreas failing now, and there's reports where people are becoming more diabetic in certain seasons of the year, during spring and early falls, and we don't know why, but some people are ascribing it to viruses. We have billions of viruses that we still do not know about. Now, the type 2 is also, and it has an inheritable form of it, in the sense that if your dad is diabetic, or your mom is diabetic, or either one is diabetic, you have a percentage risk of becoming diabetic. And they used to say, if your mom or dad is diabetic, you have a 30% chance of becoming diabetic. But if you have both of them becoming diabetic, then the chances increases from 30 to 55%. So those are risk factors. Now, there was an entity one time that was described as maturity onset diabetes of the young, where you find that young active men or active individuals, but usually obese, are diabetic. They were becoming diabetic, and that's the entity, the premise of the obesity, epidemic and obesity syndrome that was discussed, and some of those have been discarded now. So it's almost like a perfect storm. If you have a high risk of diabetes, meaning a family history, and you become obese, your BMI is greater than 25, or become morbidly obese with a BMI over 40, then the risk of you becoming diabetic is really very high. Now, I've had some patients who are skinny, they watch what they eat, they exercise, they do everything else, and now they're becoming diabetic. And that's another entity we'll really begin to see. And that's the entity called LADA, latent autoimmune diabetes of the young, of the adults. Now, what does that mean? It's still an entity, we're learning about, where you find out that normal, regular, skinny people, plus or minus family history of diabetes, are becoming diabetic. Now, why? Is there an inherent genetic predisposition to it? Yes, we're working on that. Or a virus interacting with some components of the pancreas or anywhere else that's predisposing people to becoming diabetic. Yes, they're working on that. And that in itself is an autoimmune form of diabetes, meaning you produce antibodies against, the enzymes that are responsible for producing certain proteins that help you, your insulin to work better. So those are things that begin to happen, and we're learning all that. So in the perspective of everything else, whether it's 1, 2, or, LADA type, the essence is you need to, one, go to your doctor, check your sugar when you go in, and then ask for them to screen you to do your A1C, meaning it will tell you what your sugar has been in the last 3 months and where in the spectrum of diabetes that you are, if you're not, if you're pre-diabetic, and if you are. So that's one of the first steps to go about that. And then the doctor would, better educate you on what next to do. If you're pre-diabetic, then, lifestyle changes. I had a doctor and a commissioner of health who told me recently that he didn't know he was pre-diabetic until he started having some burning sensation in his legs. Because he's a doctor and he knows that burning sensation in his legs can be the first sign, he went to check. And he found out he was pre-diabetic. I've had people who wake up 4 or 5 times in the morning, at nighttime to pee, and that's an early, sign of diabetes in itself. So they go check, and then they find out. But we shouldn't wait for those times. So at a point level, when you go see your doctor, ask your doctor, let me know my baseline level of A1C and where I am. If you're not diabetic, fine. But if the family history, then you need to watch what you eat. You need to exercise. You need to, cut out certain foods if you have a family history. If you are diabetic, lifestyle modification. If you become a lifestyle medication, and then medication as intervention, and subsequent follow-up with specialists that are required.
Well, thank you. Thank you so much, Dr. Nelson Aluya. I have a text from Efua Atta. I don't know where she sent the text from, but quote, from 2 weeks up to now, I have been experiencing dry mouth with pain from my tongue, both day and night. Please, are these signs, symptoms of diabetics? She didn't write diabetes. She said dietetics. Is there something like that? Or maybe she wanted to say diabetes? Hello?
Yeah.
Let's assume that maybe she wanted to say diabetes. Is it signs or symptoms of diabetes? Because for the past 2 weeks, she's been having dry mouth with pain from her tongue, both day and night. And she wants to know whether, I believe it's not that, I think it's diabetes that she wanted to say, but she wrote dietetics. And pardon my ignorance, because I don't know anything about medicine, maybe there could be a condition called dietetics. If there is none like that, then I believe she wanted to say diabetes. So let's assume that it is diabetes that she was referring to. She wants to find out, is it a sign? Anyone wants to help her answer her question?
Well, this is Dr. Rockton. If it is dry mouth, and how long has she had it? You said about 2 weeks.
Yeah.
Dry mouth, dry tongue. It could be diabetes. It could be lack of. Could also be lack of certain nutrition. So definitely, she has to see a dentist first, and then if anything else, we can just follow up with a physician.
Okay. Theater. So there you go with an advice. See your dentist, and then hopefully, it's not all that you don't have to see a physician.
Yeah,
but
because sometimes it could be medications. Certain medications can also cause dry mouth. Whoever sent the message did not tell us whether they started any new medication or not, so we can't really.
And like I said earlier on the program, as a disclaimer, this is not an attempt to look at one size fits all. We are just trying to bring awareness. In all cases, you have to see your doctor because we are all different. We have unique physical characteristics and hormones and all those things. So you might just ask your question. You might want to see a dentist and then follow up with your doctor. Now, let's stay with what time is, 3:35. We have 25 more minutes to go, but let's stay with our lifestyle habits and dietary in Africa. Most of the stuff that we eat in Africa, most of us basically carbohydrate or carbohydrate-based food. Are you specialists telling us that they are not good? Because they will turn into sugar. Dr. Badu, you said that, but can it be, at least you know some Ghanaian food, then we'll go to Dr. Aluya and maybe he will tell us about some Nigerian food. Dr. Badu, are you saying that some of the foods that we grew on in our villages could be the cause of diabetes?
Well, Kofi, the food that we grew up on, clearly it's a good food because it has sustained generations and generations over centuries of people. So I cannot say it's bad, but everything is within proportion. I mean, back in the olden days, we didn't have cars, we didn't have all these modalities of travel. People used to eat and walk from place to place. So the food that you eat, although our food consists of a big portion of it is high in carbohydrates, it's able to be used effectively for energy purposes. Nowadays, because of the westernization of our continent and even in this country of how people live with our lifestyles, there's lack of exercise, which befalls all of us because of our workload, whatever we do, and we tend to overeat. We tend to eat the same food, but we don't have the same level of activity. So, by essence, the carbohydrate food that we eat ends up being converted for storage purposes and becomes fat. And then it gets stayed in the system, doesn't get utilized, and we get prone to becoming diabetes. So it's not that the food is bad, it's just that if we're going to continue with those same type of nutritional ways, we have to now do it more in proportions, cut the volume down, increase our vegetable intake a lot more, and drink more fluid, because our energy requirements are a lot less than what our forefathers used to be.
I see. Well, there is a text for specifically for Dr. Aluya. It is for Dr. Aluya Nelson. Do you do A1C test in your office? Janice wants to know. This is from Janice.
Oh, yes, I do. As a matter of fact, every patient that I see for the very first time, I see adults and children also. For the kids, if you're less than 18 years old, I would not necessarily bother to do an A1C. But if there's a strong family history of diabetes in that family, and that's why we take very strong history from everybody who will see for the first time. History, and then physical forms a huge hallmark of making diagnosis. So the strong history, if you're less than 18, strong family history, yes, I will screen you for diabetes. Or if you're obese, but you're still, very young, less than 18, I will screen. But everybody who's 18 and above that I'm seeing for the first time, I will screen. Just to get a baseline levels of what his or her diabetic status is, so I can adequately advise them. Now, on the level of the food we eat in Africa and if it's bad or how it relates to diabetes, I just gave statistics earlier on at the beginning of incidence rate of 1.6% in Africa way back in the 80s. And as a matter of fact, there's some old literature that said Africa was basically devoid or absent of diabetes. But that incidence rate right now from 1.2, 1.6 is about 7.1 as we speak. And that's within a short time, and it's actually increasing. So, but like Dr. Badu said, the same food has sustained our forefathers generations and centuries back. But it wasn't a big issue. So from the 80s to the 90s and where we are now, what has changed? A couple of things have changed. Science and technology is great, it's amazing, but also the downside of science and technology we have to deal with. In the United States, they understand that. There are people who study those things on a daily basis and know how to take steps to mitigate those things. We need to start doing that back home also. Why? What has changed? Science and technology, like I said, and sedentary lifestyle. Back in the days when you went to talk to grandma, you walked to grandma's house, or grandma walked to your house. Less and less cars, less and less transportation. It's not like any of these things are bad, but it's just that we need to find ways to increase our activity levels. So as the sedentary lifestyle begins, we begin to gain weight. As a matter of fact, there's a huge comparative a diagrammatic study of obesity and diabetes in America. If you look at the graph, they basically follow the same pattern. They look exactly the same. As the number of people who become obese in America increases, so also the number of people with diabetes also increase. The graph is essentially the same, you know. But within the last a year or two in the U.S., they took steps about those. So it actually plateaued in 2014, and then in 2016, there's a dip in the amount of people who became obese. But unfortunately, we've not seen that same dip in the number of people who are reported to be diabetic. So why? It's the same, sedentary lifestyle. More and more people are not moving as they ought to. They're eating whatever they want. And the same thing is happening in Africa also. And then the other part of it is the food that we eat. How many people are in the farms anymore? Most young men are not farmers anymore, even in Africa. They import most of the food they eat. Imported from China, imported from India, imported from everywhere else. It's not the same authentic food that our forefathers knew when they were growing up. So things are changing. And those, are issues that are resulting in the number of incidents of diabetes that we have in Africa. So if we, as Africans, can go back to farm, generate and produce our own food as we ought to, then things will be a lot better. So that's where the government comes in again, where they need to, spur on people to go back to the farms, produce their own food, and not just, import food from everywhere else. Processed food. Those are issues that we talk about, and that's why here in the U.S. you hear people running back to the farms talking about organic food. So yes, we should do more organic food, because if we don't, then we should be ready for the fallouts of what's going to happen.
Let's get Ms. Padilla here. With your work in the community, would you agree to what Dr. Oluya is saying, that dietary habits have direct effect on obesity and by extension diabetes?
Yes, I do.
Also, why? Yes, why?
I agree. I agree, because it's right. A lot of the people in the community, the exercise, they're not doing that. Exactly like he says, they are more into the processed food, the fast food places, and that's what makes the diabetes in you. It's eating the wrong choices, and that's part of what we try to teach as well, how to make the right choices in your food. The fast food places do not help us. It doesn't help at all. And a lot of people with the style of life that we're living now, the fast pace, that's what we go for. Whatever is available, whatever's the fastest. And the lack of exercising, all that affects us in every way, because a lot of the young people and even the old people, instead of, like he said, walking to grandma's or walking over here, you jump in a car and you drive, or instead of walking over to talk, you text or you call. All technology is also affecting us, because it makes us a little bit less active, and that cuts us in doing our proper exercises and stuff. So I agree with him. Yes, I do.
Thank you. We got 15 minutes to go. Coming up from 4 to 6, Ghana at 60. So it's a marathon program for the crew of Anything Africa. And our crew consists of Kofi Ayim, Dr. Kwame Akono, our producer, Sadiq Abubakar, our director of programs, Mam Bote, and then, of course, the co-MC, Dr. Kwame Akono, and our technician, who is Bella. Let's go to Dr. Andrew Badu. The first time, in fact, I got to know Dr. Badu through Dr. Roxon, and he said, I'm referring to a nephrologist. I heard nephrologist. I said, does he study frogs or something? Nephrology, frogs. But then I found out that nephrology is not the study of frogs, but something to do with kidneys. So, Dr. Badu, you tell us, diabetes and kidney diseases.
Thank you, Kofi.
It's
it's interesting that we have this symposium on this day because the month of March is a kidney month for the whole U.S. or for the whole world, so to speak, because kidney disease is unfortunately on the uprise, and as Dr. Luya had indicated, diabetes has been on the uprise, and so has the kidney disease. And the reason may be because, as we found out in our profession, the number 1 and 2 causes of kidney disease have been diabetes and high blood pressure, and they're basically interchangeable, and they kind of go together. Most people don't realize that they have kidney disease until they go to see their physician. Unfortunately, sometimes we call it the silent killers. We don't think about it. Unlike the heart or the stomach, when you know there's something wrong with your heart, you start feeling some chest pain, or you may get some palpitations, or you get some early warning signs to let you know something's wrong with your heart. Unfortunately, with the kidney, you really don't get any warning signs. The symptoms you may have or you may get are symptoms that may be attributable to a lot of different things that may go wrong with your body. So a lot of times people don't realize they have kidney problems until it's too late. And and that is what we want to try to prevent, because unfortunately for us, I should say, kidney disease is something that can be diagnosed early, and if it's diagnosed early, intervention is definitely a key and becomes successful. But when it's diagnosed late, unfortunately, there's limited amount of things we can do. Most people don't realize, in this country, with all the richness that we have, at least one out of three people, 1 or 3 Americans, are high risk for having kidney disease. Anybody who has diabetes, high blood pressure, or family history, has a tendency or high risk of developing kidney disease. There's almost about one study that I read commented there's about 26 million people in this country who have some degree of kidney disease. And there's a lot of them don't know they have it. And probably about another 300,000 to 400,000 on dialysis. So there's a lot of people that if we don't get to and diagnose and manage accordingly, we're going to see an uprise of people going on dialysis, which is what we were trying to prevent. Diabetes, on our talk today, unfortunately, is one of the most common causes, like I indicated, of diabetes, both of kidney failure, both in this country and also in Africa. Africa, unfortunately, is worse because, one, there's less prevention or different tasks available for people to do, and access to medical care is very limited. But thankfully for us in this country, we are privileged that we have a lot of access available to us, but people have to use it, which is one of the issues and one of the things that my organization that we've been trying to do, the Ghanaian Association for Medical Aid. We've been trying to go into the community to try to educate our people about better health care and how to get access to medical care, how to get access to free medical care. And there's a lot, there's a lot that we can do for ourselves. We just have to take the initiative, and that's what I'm hoping we could try and accomplish with this program today. Kidney disease, everybody, as Dr. Luya had mentioned, in his practice, he screens with A1C for every single patient that comes through. And most of us all do that, but I think it behooves each patient, anybody listening, that when you see your physician, you should always ask the physician questions. Most of the time you go see your physician, they will tell you, oh, yeah, we did your test, everything is fine. But they may not be fine. You have to ask specific questions. When they tell you your kidneys are fine, well, ask them, what is my numbers? The simplest test to do to diagnose kidney disease is a urine test. And usually when they do a urine test, it will comprise of different components. But one of the components that you look for is protein. Any signs of protein in the urine is indicative of some early damage to the kidney, and that should raise further testing and further workup by your physician. And you'll be surprised how many times I see patients in my office who come for consultations, and unfortunately they come in at a late stage, and there's nothing much you could do at that point in time for them. So early screening With blood work, even if you have no medical problems, you should at least get a basic blood test done, a basic urine test done at least once a year to check for kidney disease. You should be monitoring your blood pressure. We've been talking about diet. We're talking about all that. That is all part of the component of trying to maintain a healthy diet. Because at the end of the day, uncontrolled high blood pressure, improper diet, all affects the kidney. And when that affects the kidney, there's no medication, so to speak, that we could give you to reverse it. Diabetic affecting the kidney is called diabetic nephropathy. It's a slowly progressive disease that, unfortunately, when it happens, it's non-reversible. The only interventions that we have as a medical profession is to try to slow it down or to halt, but you cannot reverse the damage that has already happened. And like Dr. Luya mentioned, by the time it's diagnosed for you to have diabetes, there has already been some damage that has already happened already. So early testing, early changes in your diet becomes very important and very imperative to try to prevent any of this end organ damage.
We got just 8 minutes to go, and we are going to ask all our guests to do a submission as we do all the time here. But real quick question to you, Dr. Badu, or whoever may also want to chime in here. There are claims about natural remedies to diabetes. I don't know how far it's true though, but we have heard about a fruit called the African star fruit, which they said harms diabetes. How far is it true? Are there like natural remedies to treat diabetes? Hello?
I cannot comment on that. I'm not particularly familiar with that particular natural, so I'm unable to comment on that particular for you, Dr.
Excellent. Let's get 2 quick questions. Please ask your question quick. The caller with the last 4 digits 1630. Go ahead and your name, where you calling from, and your question, because we have very few minutes left.
My name is Esther, and I'm calling from New Jersey. I have a question for Dr. Roczen, and it's about diabetes and the dental hygiene. What can you tell us about this, and what is your recommendation for someone who has diabetes? How often should they go for a dental checkup?
Oh, okay. Yeah. Thanks for your question. I had mentioned earlier that patients with diabetes tend to have they're like 4 times higher risk of having periodontal disease. And when you have periodontal disease, 2 times a year cleaning is not enough. You need at least 3 to 4 times cleaning per year. Brush twice a day. Floss in between the teeth every day. What it does, it breaks down the colony of the bacteria that harbors in between the gums. So most people don't floss their teeth and they think that, well, I'm brushing and it's okay. No, it's not. So proper oral hygiene will actually help our patient with diabetes.
Well, thank you so much. The caller with the number 6447. I believe that's the last call we will take, and we wouldn't be able to take text messages, but we will have to do a part 2 of this. Yes, the caller with the last 4 digits 6447. Your name and where you calling from, and your quick question. Hello.
Hello.
Yes. You are live on air. The last 4 digits 6447. You have a question? Hello.
No, thank you. Thank you. No.
You don't have a question. Okay. So now let's start with, in fact, Dr. Roczen, you were the last person to speak. Why don't you give less than a minute summation of this particular program with respect to the dentistry? 1 minute to end the program. We ask everybody to give a very brief summary of what you would tell our listeners.
What I would say is There are so many signs of diabetes throughout the whole body, from like one doctor said earlier, from head to toe. We should listen to our body. Anything that's not normal, see that whoever is in that particular area to check for you. Like I said, when it comes to diabetes and oral care, we have to pay attention to bleeding gums, teeth that are separating. If your teeth were straight and all of a sudden you see that there's a lot of space, and find out what's going on. Maybe you're losing bone around the teeth, and therefore the teeth are becoming loose. And then this is how most people tend to lose teeth. They think that as you get older, you lose your teeth anyway. That's not true. Most of that it's attributed to gum disease, or what we call periodontitis. So I will advise everyone to see their dentist at least twice a year for checkup and professional cleaning. Thank you.
Thank you so much. Let's go to Dr. Roach. Your submission, please.
We have to amputate your legs today.
Hey. Yes, please go ahead and give your submission.
Oh, this is Dr. Roach, the gynecologist. Are you calling for me?
Yes, just give your summation 1 minute for to our listeners, what you want to tell them in summary, or in 1 minute.
All right. My short summary is that from the standpoint of the OBGYN, diabetes is very, very important. It does affect many of the things that we do, from what outcome we're going to be able to give people who are pregnant, because I talked a little bit about the negative effect of diabetes, particularly poorly controlled diabetes, on pregnancy and also on delivery and the newborn. It affects many of the things we do in terms of treatment. If you have a simple yeast infection in your vagina, if you're a diabetic, that's complex infection, and it takes more effort to treat it properly. When we do surgery, we need good diabetic control, and the diabetics who are not in control present more of a problem both in the operating room if they're obese. The surgery is more technically difficult. Also, more risk in terms of clotting and problems with wound healing, etc. So even from the standpoint of a gynecologist, this is very important. We do spend time. We do screen. And everybody has to understand that the body has to be taken care of. It is not something that you can neglect. Simple things are the basics in terms of trying to prevent diabetes that's caused by the changes from obesity and overeating, and good diet, maintaining a normal weight are of paramount importance.
Thank you so much, Dr. Roach. Let's go to Dr. Babu.
Yes. My last comment is, kidney diabetes is a bad disease, and diabetes, of all the things it does to your body, to me, the most important thing is the diabetic nephropathy, the damage to the kidney, and that needs to be taken seriously. Kidney disease kills over 90,000 Americans every year, more than breast cancer, prostate cancer combined. So this is a disease that needs to be addressed. More attention is to be paid to, but the attention needs to come from us as individuals. We need to take better care of ourselves, eat better, increase our exercise activity, decrease our carbohydrate intake, make sure we see our physicians at least at a minimum 1 to 2 times a year. Make sure your physician does the basic blood work, which should include a basic urine test, a basic blood test, and they need to communicate with you and let you know what is abnormal, what is not. Take an initiative in your own health care. Ask questions. That's the only way you could help yourself and help others.
Well, I believe last it will be Dr. Aluya Nelson, who actually brought this topic for us to discuss. And we say, if you think you have a team that will be very, very beneficial to the community, please just let us know. And before he speaks, I just want to bring, if you want to contact any of these doctors, please 017045838. Dr. Nelson Aluya.
Well, thank you very much, Kofi, and thank you for a wonderful discussion and all the panel and the listeners and those who called in. There's no doubt that this creates awareness and something that needs to reach out to communities. So the information that we get from here today, we need to take it out there. First, imbibe it on an individual level, and then spread the word. Ask your family members, talk to your community members, talk to your friends and relatives, talk to people who are in government. If you're in government, it's important. In Africa now, most of the emphasis that's been placed on HIV and TB, but studies have shown that there's an association between diabetes and HIV, not in a causal relationship, but with the medications that are used to treat HIV. So more and more people on HIV are living longer, so also the risk, even from the medications, is increasing their risk of diabetes. And also for TB, it's about the same thing. There's a causal relationship in that respect on a molecular level of TB and diabetes. So in essence, everybody basically just said everything. But what I would wrap it up as is, one, learn to understand your body, because you're the only one, except when you're asleep, who is with yourself 24 hours a day. I mean, you go see your doctor, it's 15, 20, 30 minutes at the most, and then you're gone. And then you don't see him again 3 months or 5 months or 6 months or a year, but you're with yourself. So learn to understand your body. And if anything is going wrong that is unusual, then seek help. Ask your doctor. And when you go before you go to see your doctor, do some research. Go back, read a little bit, but go see your doctor. Why? Because a lot of the time, whatever you read online will always give you the gloomy and the end of it. So when you see your doctor, he'll be able to understand and teach you better about these diseases and whatever signs and symptoms that you're getting. So, and that's the essence. And not just that, as Black people, one of the things that we lack, we do not share our story. We do not share our history. And it plays on every level, personal, social, and political level, even on history. So tell your family members whatever medical condition you have, because you need to tell your children, you need to tell so that they pass it on, so that they understand and know. And then they can help prevent them, because you'll be saving lives. So like I always say, take care of your diabetes before your diabetes take care of you. Thank you.
Well, and with that, we are just beyond 4 minutes beyond time, and the next program is coming up, Ghana at 60. So we'll go quickly to our producer to do the official thank you, and then we'll wrap up. Coming up, stay with us, Ghana at 60. Sadiq, go ahead and do what you do best.
Thank you very much, Brother Kofi. It's been a wonderful program. I think in quite a while we've not had this amount of response from our listeners. We really, really, really appreciate them calling in and then making a contribution. But of all the things we can say, we need to thank our guests. You all rock. That was just a wonderful display of knowledge, dedication to our community and for humanity as a whole. We have Dr. Anna Padilla, Dr. Natalie Roche, Dr. Andrew Badu, Dr. Nelson Aluya, and Dr. Agnes Edu, and Dr. William Roxon. You all have done a marvelous job, and we thank you and thank you and thank you. You all have a great weekend. And for our listeners, thank you as well. And with the leadership of Jersey Ghana Radio on the background, Professor Kwame Akono, thank you very much for always giving us the background advice as to how we should direct this program. Thank you very much. You all have a great weekend. see you next week.
And thank you. We'll be right back. We'll take a couple of minute break, and then we'll start with our second program then at 6 featuring Dr. Kofi Boateng, Dr. Isia Pipra, and Dr. Benefrifa. We'll be right back.